Okay. I see it's recording now. So.
Okay, cool. Everyone, hi everyone. Nice to meet you. I'm Liron. I am a vet and I'm the managing director for HD Vista. I'm based in the UK. However, my family, and I'm embarrassed to say that my family is from Winschoten. However, I do not speak Dutch, and that's what I'm embarrassed for. So apologies, I'm a very bad Dutch person, but I'm really, really excited to be here today. I'm sure my mom would be delighted to know that I'm delivering this to you guys. Anyway, so that's me. And what I would like to talk to you about today is our new technology. We have an opportunity to work with AEP, and Leonie has kindly agreed and invited me to speak in front of you. So I'm happy, obviously, to do that, and I'm really hoping that you will be interested in what we have to say today. So what I would like to do for the first time ever, try to run a couple of polls, see how it goes. I've never done that before. See how we manage, and if we manage, great. If not, then we'll just not do it. So let's see. So I have a few questions that I wanted to ask, kind of to see, I guess, to get to know you and kind of how you guys work in your practice. Obviously, the topic today is lumps and bumps in dogs, and let's see how it works. So I'm going to launch the first poll. See what happens. Did you get it?
I see.
It's working. So how many lumps and bumps on dogs do you see in your practice every week, roughly? Just kind of for me to kind of know if you're able to vote. So I can see that you guys, some of you have voted. So I have a couple of votes. See if you guys are. And by the way, you're more than welcome either to switch on or off your camera, your webcam. And also, if you have any questions, I think we'll probably have lots of time in the end for questions. So I'm more than happy to be interrupted, but I think just for the kind of sake of the continuity of the presentation, we'll have plenty of time in the end. Okay. Anyone else wants to kind of join the poll? Okay. Can you see the results of the poll, Leonie?
No, I only see. I mean, I didn't vote, of course, but I don't see any.
Oh, okay.
I see the first question. I know maybe if I have to answer them, and maybe then there will be a result. I can try that, but then it's maybe.
It's okay. Just maybe answer.
Yeah. Oh yeah. Yeah. Okay. Yes.
Cool. So let's see what happens when I click here. Okay. Okay. So we have a range. I'm going to end this poll. We have a range of obviously people seeing from about 5 to 6 and 10, and sometimes even 15 lumps per week, which is quite kind of interesting. I'm going to end this poll now. And the next question is I'm going to launch it now. What would be your next kind of recommended, I guess, step? Is it just to keep an eye on, or to do an FNA, to take a biopsy, or go straight to surgery? So obviously we don't know what you're voting and who is voting what, so try to be as honest as possible. Okay, so 3 have voted, or 4 have voted. 1 have kind of keep an eye on. 1 voted for FNA. 3 voted for FNA. I hope you can see the results.
I can. Yeah. I think everybody else can, but.
Okay, so we have quite a few that voted. Okay, nice. So I guess FNA would probably be the most kind of common answer, which is great. And then the next question would be, I'm going to launch it. So in percentages, I guess, what percentages of dog owners would agree to perform an FNA? So you see the lump, you recommend to do an FNA. Some of them probably will decline, some of them will say yes. In percentages, how many of those pet owners would actually agree to do an FNA? Okay. Okay. So we have about 5 votes. Okay, again, so it varies between up to 10%, maybe less than 40%, shall we say, 3 votes, and 2 voted over 80%, which is great. Okay, that's the end of this question. And the last question, I guess, for those cases that you don't manage to do an FNA, what would be the reason for not aspirating a mass? Is it the perception, your perception that the mass is benign, or maybe you don't trust FNA, maybe it's just the time constraints that you have, lack of the option of doing in-house cytology, or is it mainly the pet owner that would kind of decline any further investigation due to cost, due to kind of invasiveness of the procedure, etc. Yeah, so I can see that most of you have the same experience with, we want to do a good job, we want to do what we think is right for the patient, and then they decline. Obviously, the pet owner declines because of the different kind of reasons. Okay, perfect. So thank you for that. So that's just to get you into the mode of kind of lumps and bumps. I'm sure you all have a very busy day, so we'll just crack on and start kind of that presentation. So, and the way we are presenting the topic is by kind of creating this kind of scenario of 20 dogs in a waiting room. So just kind of, again, imagine those 20 dogs in your waiting room, and those 20 dogs might be kind of in your waiting room, obviously with lumps and bumps, in your waiting room in a day, in a week, in a month, right? It's just kind of to get an idea of what we're talking about. And the question is, how do we spot those 3 with malignancy, right? Because if you think about it, we know that statistically, the prevalence of malignancy within lumps and bumps is relatively low. It's only 15%, which means that if you have to guess, 85% of the times, you probably will be right saying it's benign. But that actually makes things a bit more difficult, right? It makes more difficult because the art in medicine in this kind of scenario is actually to spot those 3 that have the malignancy, because we don't want to miss them. We don't want to send them home. Okay, and obviously, as you know, you have kind of this listed in front of you. Those 3 might have different type of either dermal or subcutaneous malignancy. If it's mast cell tumor, which is the most common one, but can be any kind of the others, like soft tissue sarcoma, fibrosarcoma, and all kinds of other maybe less common, but still potentially can be there. So what we want to do, we want to ensure that we are not missing those 3 and accidentally sending them home and miss this opportunity to diagnose them and obviously save their lives. And as you, most of you, if not all of you, if I remember correctly, mentioned FNA. FNA is a great tool in diagnosing cancer or diagnosing malignancies. The problem is that the reality of FNA is a little bit different than what we think. And again, it might be that in your case it's the same or maybe different. We have had, or we have run a few surveys. I don't know if you know Clinician Brief, if it's something, if it's a kind of organization that is well known in the Netherlands, but Clinician Brief is a very kind of big organization in the US and also common in the UK. And we ran a survey with them, and what we have found is that only about 40%, less than 40% of lumps and bumps in dogs actually get aspirated, which means that over 60% of those lumps and bumps actually go home without getting the diagnosis that they need. Most cases, as I mentioned before, probably will be okay, right? Because again, the prevalence of the disease, the prevalence of malignancy with those lumps and bumps is relatively low. But we might send some of those malignancies home because we don't know. It's really, really hard to understand or to diagnose malignancies based on palpation alone. Another kind of interesting, or a few more interesting facts, is that what we have found is that only half of those 40%, so 20% of those lumps that are actually aspirated, only half of them are sent out to the lab. The other half are tested in-house. So do a cytology in-house, and every one of us has different skills when it comes to cytologies in-house, and we all know that it varies, and there are some vets that are very good, or even nurses and technicians that are very good at doing cytology, but there are that are challenged with this kind of skill, and sometimes we can miss malignancies even if it's there. And the last very interesting fact is that multiple mass cases, so any dog with more than 3 masses are less likely to get an FNA done. And it makes sense, right? Because you have a dog that comes with like 10 or 15 even masses all over their body. These Labradors. Are Labradors common in the Netherlands? So those Labradors with lumps all over the body, are you going to aspirate all of them? I don't know. You might do, or you might not. Quite challenging, those kind of cases, and probably that's the reason why those cases specifically are less likely to be aspirated. And as for yourself, initially, as you did, those vets that have been included in the survey shared their reasons why they have been or they've decided not to aspirate. And interestingly, they have actually shared that in their case, most of them actually thought, or the most common reason was that they thought the mass was benign, or when they think the mass is benign, they don't feel the need to do an aspiration. But all of the other reasons are again related, or not all, but some of the other reasons are related to the pet owner, mainly due to the costs. And mind you, I don't know how much you charge for FNAs or cytologies, but in the US, especially, and probably in the UK as well, FNA is very, very costly in some areas. I know that in some areas I've had people charging up to $250 US for an FNA. So we can, I guess, understand, given the world global situation at the moment, why people might decline $250 worth of tests, where potentially 20% of those tests are also non-diagnostic. So we need a better way. We need to create a better workflow or pipeline to really identify those malignancies. And the reason is because any delayed diagnosis has lots of implications on the pet itself, right? On the pet, because obviously if we diagnose those malignancies on time at earlier stage, we also improve the prognosis, especially when it comes to dermal and subcutaneous masses, right? When it comes to those type of masses, we know that early detection means saving their lives, and we can just very easily remove the mass at low grade with good margins and cure the patient, right? And we can literally save their lives within a few minutes. But it has also other implications. And when it comes to the pet owner, right, and the anxiety and the stress they are in, we can really very quickly give them maybe better results. Also yourself, as the pet, as the caregivers, you want, as I think we mentioned it before, you want to do a good job. We want, as vets and nurses, we want to do the best for our patients. We have been trained many, many years to offer the best care, but when it's restricted by, if it's cost or other the pet owners that decline further investigation, it can be quite frustrating, right? Quite be demoralizing for the team. And also, if you look at it from a very, very cold and commercial point of view, you are sending home surgeries, you are sending home revenue, that you can keep in your practice and use this revenue to grow your practice and offer better care to your patient, right? So it's a vicious cycle. And I'm hoping that by now everyone agrees that diagnosis of cancer or malignancy based on palpation alone is not something that we agree on, right? We want to make sure, like I said before, that all masses, all lumps and bumps get a diagnosis. We don't want to delay the diagnosis because we know of the implication that it holds. And that's where kind of we come. So we want to give you a tool that helps you do more FNAs, do more surgeries, take more biopsies. It's very, very important to mention here and be very, very clear about that. Our technology is not here to replace an FNA. FNA is a great tool. We validate our technology with FNAs, with cytologies. FNA is a great tool. However, like I said, the reality is that it's not being utilized properly. So we want to give you a tool that will help you do more of those. So our technology is called HDI, or heat diffusion imaging. So what is heat diffusion imaging? Heat diffusion imaging is a new kind of obviously technology that is based on heat waves. And what we have found, well, I guess not we have found, but as some of you might know, every biological tissue has a heat capacity or a heat signature. And that is based on different physical and metabolical and physiological differences between tissues. So for example, if you kind of imagine two objects, not non-biological, like metal spoon versus a wooden spoon. When you heat them up, they will transfer the heat differently, right? And exactly the same is for any biological tissue. What we have found is the differences between benign and malignant tissues. So benign and malignant tissues behave differently when they are exposed to heat, when they get kind of heated, when they are excited by a heat wave, and quite interestingly also as they cool down. So what you can see, and I'll show you the product in a second, but inside the probe of the product, you have those two heating LED on both sides. They heat the tissue for about 6-7 degrees Celsius for 10 seconds. And then they allow the tissue to cool down for 30 seconds. So all in all, the scan itself takes 40 seconds. And what you can see in the middle of the probe also is a thermal camera. The thermal camera collects the thermal activity within the tissue during the 40 seconds. It records all those activities. It extracts all the thermal kind of features from the tissue, which then all this kind of data will be analyzed by algorithms that we have trained and validated with cytology and histopathology. So we have a set of algorithms that know how to differentiate between benign tissues to those that potentially malignant and require further investigation. And we have also developed a few algorithms that are more tumor specific, so that they know how to identify specific type of tumors, and I'll show you in a second. What I want to show you now is some kind of behind the scene images and video. So if you think about it, during the 40-second scan, a thermal video is created. So the thermal camera takes about 640 frames from the tissue as the tissue gets heated and cools down. And it creates a thermal video that I will share with you now. It's important just to mention that when we scan a tissue, when we scan the area, we include within this area the mass itself, which you can see under the orange circle. That's the mass. And also anything outside of the blue line that you can see is the healthy tissue that is next to the mass area. So when we scan an area, when we talk about a scanned area, is the area that includes the mass itself, but also the healthy adjacent healthy tissue. Okay, so what I'm showing you now is two videos. I'm showing you, I haven't started them yet, so I'll start it in a second. but you will see the lipoma versus a mast cell tumor. Okay, so we'll start with the lipoma. At the bottom, you can see just a snapshot of the thermal from the thermal video, and also how the pattern, how the algorithm behaves, and the comparison between the healthy and the suspicious area, here. And you can see already, you can with your eyes, you can kind of identify the lipoma. You can see how kind of cold, right, it is in comparison to the healthy tissue around it. But what I wanted to show you, I guess what's unique about the technology is that it doesn't like I said, only take a snapshot. It takes the whole kind of time during the heating and the cooling down period as the tissue is actively being heated. So it's an active process. Okay, so let's start the video and you will see the lipoma. So this is the lipoma, and you can see how the whole area gets heated, but the lipoma probably doesn't get as hot as the surrounding tissue, and it also doesn't cool down in the same kind of pattern as the surrounding tissue. Okay, this is obviously a very kind of nice video. Not all videos are very clear, but this is a nice one to kind of explain the theory behind the technology. Okay, so this is, for example, a lipoma. And I just want to stop that. And on the right-hand side, you can see a mast cell tumor, and I'll start the video now. The mast cell, as you can see, will be on the left-hand side, and you already can see that the mast is already hotter than the surrounding tissue, especially during hotter than the lipoma. And you can see that, again, the pattern is different. You can see on the kind of the graph here, it looks different than the lipoma. It has all kinds of kind of small features that are collected, these kind of dots. It looks different than the one that of the lipoma. The good news is that we don't need to worry about that, right? Because we have trained algorithms that know how to identify those kind of differences, and the output is a very easy language to interpret, but also to communicate the patterns. So every scan will result in a report, and the report is displayed to you on the tablet, but also and also on the a PDF report is emailed to you to your practice. And I guess the best way to explain it is that each mass is going through two steps. One step is the initial screening process, which produces a cancer risk. So every mass that gets scanned will get a cancer risk, either low, moderate, or high. Any mass that gets a low cancer risk is considered to be benign. It's 98% chance of being benign. So the negative predicted value of the process is 98 minimum. So that's obviously a very good kind of outcome. And therefore the recommendation is to monitor, and FNA is not needed. If the risk for malignancy is increasing, then the cancer risk will get higher, obviously, or moderate or high, and then the recommendation will also change to further investigation needed or recommended. And these are the type, this is the group of masses that you will need to investigate. So basically what the tool does, it triage your masses. It split the group of masses that you see into two, those that are safe to send home and those that require further investigation. And this is the group that you will do an FNA on, and you will have more chances of finding the malignancy. So we are removing as much as possible benign tissues from the group to really kind of concentrate this group. And once you sample them, you will get those malignancies. The second step is that every mass the data will also go through our tumor-specific algorithms, and in about 1 in 5 cases, you will also get a diagnosis displayed to you, just obviously to make sure that everyone agrees and understands, this is not a definitive diagnosis, but it just gives you an indication of potentially which kind of type of mass you're dealing with. And the specificity of this process is 90%, which means that if we say to you, this mass is a mast cell tumor, then potentially 90% of the time, it is indeed a mast cell tumor. Okay, and we have currently 4 tumor-specific algorithms, as you can see here in front of you. Most common ones are obviously the lipoma on the benign side, and all the mast cell tumor on the malignant side. Okay. So just to share with you the kind of data set, and we are very kind of proud and happy to and transparent about how our data set looks like and the reasons why we've kind of decided on those kind of cutoffs. And as I've mentioned before, the sensitivity, or maybe I didn't, the sensitivity of the cancer risk process is 90%, and the negative predicted value of the cancer risk process is 98%. And when it comes to the diagnostic finding, we are looking at the specificity mainly, which is 90%. This is how our data set on the right-hand side, you can see how our data set is distributed throughout the cancer risk. And you can see that this kind of very, within the kind of low cancer risk, you can see most of the data is blue, which means that these are the benign processes, the benign kind of masses. And this very, very fine little line, red line, within the low cancer risk group is the 2% that is a false negative. But obviously we are very happy with that. This is a very good performance. The reason why we are recommending to take a sample from this point onwards to the right is because of the increased risk for malignancy. You can see the volume, the number of red of malignant processes is increasing when it comes to the moderate cancer risk group, but obviously more kind of dramatically during the within the high cancer risk group. So that's the reason why this group needs to be sampled, because you have more chances of finding the malignancy. Okay. And again, just to finish with talking about the outcomes. So if you, once you start kind of using the product, you will see that you will potentially have 5 outcomes that you can get from the product. The 3 cancer risk groups, right, without a diagnostic finding, which is the low, moderate, and high. And then you have the low cancer risk group with a diagnostic finding and the high cancer risk group with a diagnostic finding. And you can see what kind of quite nice, nicely this kind of slide demonstrates, again, is the increase in risk, and the reason, again, to justify a sampling of the tissue. And this is really important because that's what we're trying to do. We are trying to convince the pet owner to agree to perform an FNA or to take it to surgery, take a biopsy. And you can see that the chances for malignancy is really, really low when it comes to low cancer risk, especially when it comes to the diagnosis. The cancer risk also drops to 1 in 200, so that's 99%, 99.5% negative predicted value when it comes to those kind of this group. But you can see how the malignancy, the risk for malignancy increases as it comes to the other groups. And this is why this group needs to be investigated and sampled. Okay, you know what, I'll stop for now for a second, just to check how everyone is doing, see if anyone has any questions. Feel free to either type or ask. Just unmute yourself.
There's nobody anymore in the waiting room, Liron, just to be sure.
I'll double check. No, I didn't get a notification, but
okay.
No, I didn't. No.
Okay.
Okay, cool. Maybe you're a bit shy yet, so I'll let you just. Okay, so I just wanted to introduce to you the product itself that delivers this technology. So this is the product, and the product is called Vista IQ. So it's a non-invasive handheld device. Okay, and I have it here with me as well. Okay, so this is the scanner, and the reason why it looks like that is because it's very unique. And it's V for Vista, but also we've designed it ergonomically to make sure that when you scan, it kind of really kind of supports you and kind of limits the movements. And when you scan the patient like that, you can hold in different ways depending where the mass is. So we've consulted with ergonomic designers, and that's the design that we have decided on. You have also changing heads that you can remove and replace with a smaller one. So if you have a limb or a tail or maybe a little dog that you want to scan, it's just easier to scan it with this little head. Okay, and it comes with, oh sorry, the way it looks, oh my goodness, the way it looks like when you scan, during the 10 seconds of hitting, there is this kind of blue light that the device generates, which is very nice, very good for social media, by the way, if you are interested. And also it comes with, it doesn't come, but it kind of speaks to with an iPad, and there is a software that obviously we provide together with the device, which I'll show you in a second, the video, how it looks like when you scan a mass. So it looks very nice. The software, the interface is very kind of interactive and easy to use. The process is very, very simple and quick. You need to clip a small patch of fur, scan for 40 seconds, and then within a couple of minutes, you get the results. And the best thing about the product is that the nurses can do it, that the nurses, technicians can do that and should be doing that. And we've noticed that practices that utilize their nurse team are performing best and really kind of use the product and are very, very successful with this technology. So normally the receptionist will book an appointment with the vet, but before they see, before the patient sees the vet, the nurse will triage the patient, find all the lumps, scan and get the results for all the lumps, and then the vet will do the full vet consultation with obviously knowing the result already. So the next step can be decided very, very quickly, together with the pet owner. So just quickly how it looks like when you scan a patient. Okay, so you have a 3D dog map that you can rotate, find the lump, drop the pin on the lump, start scanning. There is a live stream that shows you the area that is scanned. As I said, we are scanning the mass and also the healthy tissue next to it. And then in a moment, it will kind of fast forward. I think there is a question, I'll answer it in a second. And then, like I said, within less than 40 seconds, everything is kind of ready. All the nurse needs to do is just to place a marker on top of the mass area, separate it from the healthy tissue with a buffer zone, and that is it. Within 2 minutes, all the calculations are done, and you get the results to your tablet, and also a PDF report is sent to your practice. And for that, for example, in this case, it was a low cancer risk with a sebaceous adenoma diagnosis. Okay, and this is again another example of the reports. I guess I just want to I wanted to show that it's just a very good kind of. It's nice to see how firstly the blue results give you a very quick reassurance to pet owners say, oh, I don't need to wait another week now for the FNAs, for cytology to come back. But when it comes to moderate, specifically the high cancer risk, it's quite alarming. It's quite kind of to say, right, something is wrong with this mass. You need to sample this mass. And they find it really, really tricky to say no to. Let's just check what the answer to the question was. What is the percent for moderate? So the percentage for moderate is 1 in 4, so 25%. So 1 in 4 cases that gets a moderate result will result in malignancy. The software is our software that we developed, and it's used on an iPad. So an iPad, and soon hopefully will be available on iPhones and then Android, etc. Yes, and everything obviously requires a Wi-Fi. So the way it works is that both the iPad and the device itself are linking to the internet, to the clinic Wi-Fi, and that's how they communicate. Okay, there are some limitations that I wanted to share with you quickly. The most, I guess, important one is that the eyes, we just can't scan eyes. It's just not safe. Lymph nodes, just because people ask, although lymph nodes, testicles, and mammary gland tumors are not considered subcutaneous tissues. They're not originate from the subcutaneous kind of tissue. But just to mention that they are not kind of suitable for scanning, although we are running some tests now in Sweden, in Italy, in the US, on mammary glands. So we are hoping that we can include them in future algorithms. Footbeds can be scanned. It's just sometimes a little bit tricky depending on the location of the mass. And ulcerated masses, it really depends on the mass size, I guess, and how big or small the ulceration is. Obviously, if the whole mass is completely ulcerated and necrotic, it's not suitable for scanning, but I guess that's a mass that I would potentially, or clinically, I would recommend removing anyway. But if it's a small focal kind of ulceration within a big mass, you can still scan the mass. As long as you scan the mass area with a healthy tissue next to it, so the edge of the mass, that should be okay. I just wanted to quickly share with you, I know that we have a few more minutes left and then we have time for questions. Just share with you some kind of commercial maybe information that you might be interested in. We know that from our customers within the European kind of countries, they charge anything between 50 to 60 euros per scan. Some of them charge different kind of charges depending on their kind of pricing structure, but just for the sake of explaining the slide, we use this this pricing structure. So a scan about 50 euros, sorry, 150 euros for an FNA and 800 for a mass removal. And what I wanted to explain, to demonstrate, is that every cancer risk result that you get statistically will result in a certain kind of number of kind of revenue. Obviously, low cancer risk results will end up with a £50, right? Because you don't do anything but just £50 and send them home. And then because there is 25%, as I've mentioned, chance for malignancy within the moderate and about 67% chance for malignancy on average, within the high cancer risk, each of them will result in a different next step, and on average will result in this kind of income. So 400 for the moderate and 736 for the high cancer risk. And the reason why I'm telling you that is that just to show you the return on investment, because the return on investment, how you pay back basically for the device and start making money as well, is by not only scanning, but also with the additional revenue that you get from surgeries, predominantly from surgeries. So what we've done some surveys and pilot studies with clinics before and after they got the Vista IQ, and we noticed that there was a difference of about 2.6K per 20 cases for those clinics on average, which brings the ROI for about 3 to 4 months. So you pay back for the product that you purchase within 3 to 4 months, and because you'll see in a second, because if you purchase the product now, you get 3 years of free subscription. You basically have more than 2.5 years of a product that you have already paid for, and generates kind of income and revenue for you. So this is something that we have agreed on and we are proud to introduce. If any of you would like to, or interested, or would like to pre-order the Vista IQ, Leonie and her team has kindly agreed to offer you 10% off until the end of April, which brings the product's cost to about 11K. And within this 11K, you obviously own the product, you buy the product, but you also get 3 years plan, unlimited, completely included, and free. And like I said before, the ROI is about 3 to 4, let's say even 5 or even 6 months, depending on the size of your practice. You have about 2.5 or more years of just enjoying a product that generates income for you from mass removal surgeries. Cool. So I'm done. Thank you very much. I know that it's 45 minutes now, but I'm more than happy to stay if you want to answer any questions you two might have. I'm happy to answer any question now.
Somebody sent 2 questions in the chat. I don't know if you already.
Yes, I think I've already answered.
Okay.
The questions.
Okay.
Yes. Yeah.
All right.
Any other questions that I can help with?
So in principle, you are having to use an iPad to be able to see what comes out of it on the software.
Yes. So this is the iPad. Yeah. So
Yeah.
You need an iPad. Yeah, you need an iPad, and that's how you scan. You can see the 3D dog, and the product communicates with the iPad. Yeah.
Yeah. And I'll take it then as also seeing the software is online with you guys, that you always have to be having an online connection. And also, I take it then that you'll use whatever we scan and what other people scan to evolve the product.
Yes, correct. So firstly, yes. So like I've mentioned before, the product, the scanner and the iPad need to be connected to Wi-Fi. As part of your plan, you also get unlimited software updates. And what it means that every time every probably about 2 to 3 months, we launch a new software or updated software with new features or new algorithms. So for example, we are now working on a soft tissue sarcoma algorithm. So once it becomes available, it will pop up on the screen to update the software, and you will get everything included within your new software. And yes, what we have seen quite nicely, it actually comes from clinicians, from customers that want to improve the algorithm for them, right? So they currently, our customers, if they want, they share with us their results, their lab results.
Mm-hmm.
We then take this information and we train the algorithm based on that as well. I didn't mention it before, but currently our algorithms use a supervised training system. What it means that we humans still supervise the learning of the algorithms and also test them, because we don't want to release any algorithm that has not been tested, that they just do whatever they want. Right? So yes, currently our customers we use this information from customers that want to share with us, and it's really helpful. Regardless, we work with oncology groups worldwide, so we collect data regardless. So the data collection is ongoing. It's really nice to actually get some information from clients as well.
So from the clients, you also get the FNAs so that you can consider that compared to your analysis.
So we know exactly. So we see obviously everything in terms of the scans. We see everything. So they tell us this patient, this mass, this date, and this is the lab report. So we kind of link everything together, and that's how we train the algorithm to understand if it was right or wrong. Mostly it's right. but also extract new features that for specific type of tumors.
And this particular product is already running in which countries?
So we launched the product, the first generation. We launched the product more than 3 years ago, mainly in the US and the UK. We have some countries in Europe that are using, like Sweden, Germany. Is Greece? Greece is included in Europe. I'll let you decide on that.
Yes.
I'll let you decide. So yeah, so
Still
Greece,
European Union.
exactly. So Greece, and we have also a Switzerland as well, and Australia as well. So the Netherlands is a new market that we are now exploring together with Leonie and her team, and Belgium. I keep forgetting Belgium.
Okay.
Yeah. So so the first generation has been running for over 3 years, and it's been delivering very, very nice results, and everyone is relatively happy. We launched the new product. The first generation is just basically the same. It offers the same technology, but it's a wired scanner. And this wireless scanner we launched, when did we launch it? March, April this year. And no, March, sorry, not March, April. We're now in March. In January this year, we launched it. And we managed to upgrade 30% of our customers already. So everyone has been kind of really happy with the third generation and really want to obviously explore this new one.
Okay.
Cool.
Then I know enough for a moment.
Thank you.
All right.
Perfect.
So if there's no more questions,
Yes.
yeah.
Just to say thank you for having me. Thank you for listening to me. I'm sure Leonie will be happy to, if you have any questions, just kind of send it across to me. More than happy to help, and yeah, looking forward to seeing what you think about it.
Okay.
Thank you very much.
Perfect. Thank you very much. Have a good evening.
Okay.
You guys too.
Thank you, Liron.
Take care.
Bye-bye.
Bye.
Bye.